Sarah, thanks so much. Stefan, it's great to see you.
It's great to see you. Welcome back, Meg.
Oh, thank you. So let's start right there with the COVID vaccine. The $110 to $130 a dose. Is that where you are thinking of potentially pricing this once you switch to the commercial market? And how do you kind of think through when that switch is going to happen?
Sure. So we've not decided the price yet. What I shared with the journal this morning is that the question was, what do you think of Pfizer range? And I said, well, this seems like a reasonable range based on the value of a vaccine in terms of savings for the payers. And so we're still going through that process. The US government has asked us to be ready to be able to go kind of the private setting, commercial setting versus pandemic setting this year, which we're all doing in terms of discussing with pharmacies and payers and hospital networks and so on, as you would expect. And so we're all getting ready to do that. Right now, as you know, the US government has ordered a lot of product, so we're able to provide the pharmacies. But it's really the goal is to be ready for late summer, early fall for the next booster season.
So thinking about how you've modeled COVID vaccine revenue, $18.4 billion in 2022. You said a minimum of $5 billion this coming year. You still could potentially strike more contracts, but how do you see the COVID business sort of playing out over time?
Sure. So I think indeed the $5 billion is the contract that are already signed, like Canada, Australia, and more countries. This number does not include any sales in the US, so that would assume we sell nothing in America, which I don't think will happen, of course. And no new contract in Europe and Japan and Middle East and Latin America and so on. So we just wanted to be clear to the market, this is what has been signed already and what we think is a flaw. That's how we characterize it. And so we're going to be working like in any pharmaceutical companies, like I used to do at Lilly, before, where you go and you just go and negotiate contract and so on to see where the year will land. It's clearly a transition year. I've never managed a company from pandemic to endemic, so I'm going to learn like everybody else, I think. I think there's been a lot of COVID fatigue this year, but I think given the infections we're seeing for COVID and RSV and flu, I think more and more people are going to be more interested to get to their booster next year. And it really varies around the world. As you know, in the US, the vaccination rate for boosters, Omicron booster, is not very high. But in other countries around Europe or in Asia, it's much higher. So I'm hopeful that over time, the data and reason will help people get protected.
Sarah? It's Sarah, Stefan. No, just on that note, you mentioned Asia. What about China? Do you think that they are going to eventually order mRNA vaccines as COVID surges there?
So, morning, Sarah. So, we are in discussion with the Chinese governments. We have been for quite a while. As you might be aware, the FT reported last week that Europe tried to give mRNA vaccines to China, which were refused, from what was reported by the FT. And so, at this stage, there's nothing to announce because nothing was signed. We're actively in discussion. I'm hoping that something will happen. But of course, it's the decision of the Chinese government of where this lands in the end.
That's good to know. At least you're still in discussions with that. I think that's newsworthy for people looking for some relief as on the China story. My other question to you, Stefan, was on the vaccine you're working on with Merck as it relates to melanoma and how game-changing you think this is and how big it could be.
Sure. I mean, if you look at the data, we compared our product to Keytruda alone, so our product plus Keytruda compared to Keytruda alone. It was a randomized study. It was powered so we could know is it working or not. As you know, because I was on CNBC in December when the data came out, we saw a 44% reduction of risk of recurrence of disease or deaths, which is very, very material. We think we have a few even solutions technologically to potentially improve it. And so what we're working with our colleagues at Merck is how could we start a phase 3 as fast as we can in melanoma. But because the mechanism is the same in all cancer, which is how can we teach the T cell, the immune system, how to recognize what they missed. Because we all have cancer all the time and our immune system has the tools to take care of cancer cells. And if our cancer grows, is that something weird happens. And so we think it's applicable to other cancer type. Could it be applicable over time even earlier? Could you see a world down the road where you have a technology like liquid biopsy, like from Illumina Grail, where you see tumors very early on in blood, and you make a product for people as soon as you have that information to help them very early on in their disease, to help them? That's also a possibility. So we're going to be exploring a lot of things. We think it's very game changer for patients And so Merck and us are very committed to invest aggressively. As we shared this morning, we're increasing our budget for R&D in 23 to $4.5 billion. That's a very, very large number. And a big component of that, of course, is cancer.